a very varied career, everything from working at Gartner to being involved at the Council on Foreign Affairs, but you're also on the board of a hospital, and you're now an entrepreneur.
Entrepreneurship at MIT.
And you teach entrepreneurship, and you're now also an entrepreneur.
Yes.
And so tell me a little about how you think about the cost side of the equation and why you chose to focus specifically on trying to increase, trying to decrease some of the costs in the system.
So you see the video, you'll see that we're doing something decidedly not sexy. We're in the back office trying to make the whole healthcare system much more efficient. And Daniel will attest to he actually forgets more about healthcare than I know, as we said before. Basically what happened is that if you've ever heard of a company called Intralinks, I was the CEO and chairman of that company, and the MIT tech team and I built that company a number of years ago. And then 3 or 4 years ago, we looked at what was going on in healthcare and saw that what was going on in healthcare was what was going on in financial services about 20, 25 years ago. And we knew we didn't know much about healthcare, and we knew we had to find something that we could do that where enterprise software skills mattered, and also where you didn't have to have deep knowledge of the healthcare system. But removing administrative waste and duplication was something that fit that category. So what we did is we interviewed 120 people, healthcare providers, hospitals, insurance companies, and basically this one theme kept recurring, which was the amount of administrative waste and time spent between insurance companies and doctors is off the charts. It's duplicative. You couldn't design a more stupid system if you tried. We showed this video at Harvard Business School last spring, and they basically said if we took the best minds at Harvard and said, here's what we're trying to accomplish, go and create the most screwed up system you can, they wouldn't come back with a system that we had. It's that bad. And so when people look at it, they would make recommendations, say, well, it's impossible that people would, even today, I'll give you a really good example. We focused on this, so in administrative waste between doctors and insurance companies. The first one we focused on was called enrollment. When you want to you can't get paid unless you're enrolled. And people generally want to get paid, so they want to get enrolled. So that's why we focused on that one first. But literally today, still, if you're an individual physician and you want to get enrolled with Aetna, you still have to go to the Aetna website and download a form, 6 pages, 35 data elements, fill it out, create a PDF, print it, fax it. I swear to God. And then it goes to India. It says 203, but it's going to India. And what do they do in India? They keep punching it back in. 25% of the time, there's an error that invalidates the enrollment. And it takes literally 3 to 4 months to complete that process. And I'm on the board, you mentioned I'm on the board of a hospital, and we won't let our doctors, we hire them right after they graduate medical school, and we can't pay them until they're enrolled and credentialed. And that takes 3 to 4 months. It's crazy. I'll shut up there. But so we focus on a decidedly not sexy thing, but we put the physician or their employers at the center of what we're trying to do to make life better for them.
So then you obviously CIO for $7 billion hospital system, and your career, you've sort of progressed to bigger and bigger hospital systems, and just so looking at the math, you probably need, the next one needs to be about a 13 or 14, because you keep on seeing to double the size every time you move to a new one. But you've been able to see from the lens of IT. And I would say having run a variety of IT publications, that it's one of the rare components of an organization that spans, like finance, spans across the organization, and increasingly is responsible for trying to be the change agent within the organization. So how do you think about the ways that IT is trying to improve the efficiencies in the system and deliver better care?
Great. I'll reinforce a point that Sumbul and Rick made earlier, that it's not about the technology. So I'm the CIO of New York Presbyterian, and we do a lot of great care. We have brilliant physicians, and people often come to us for solutions and say, this doesn't work or that doesn't work, and we'd like to buy a new $2 million piece of software. Can you make that work from a technology point of view? And we always say, oh, sure, we can make it work from a technology point of view, but really, it's about the process here. I think you want to buy this software so this group of nurses doesn't have to talk to this group of doctors, because they really don't like each other. And you'd rather have a technology solution instead of spending the couple of weeks in a conference room working on the process. So I often quote one of my colleagues who's a healthcare CIO who says, it's really about 80% process and about 15% people, and only about 5% technology. So technology is really not the answer. As a healthcare CIO, it is interesting. We get to see everything from the boardroom strategic discussions to crawling around in the basement of a 1890s hospital, following network wiring and asking why we can't rebuild the system better. It is challenging. But to your question earlier, David, I started my career as a naval officer driving ships around the world, and then I got into the telecom industry building global networks, and now I've been in healthcare for about 10 years. And healthcare is by far the most complex industry that I've ever been in. And I think the answer to the question about why can't we do a lot of things that banking does is, at the end of the day, banking is ones and zeros. And we're dealing with people, with complex cases who need to get better, and brilliant physicians who need to apply that care. So if it was all just binary decisions, I think we can make it a lot easier than it is today.
So you've talked a lot about and focused on telehealth. So how does that change the equation of the I mean, you're seeing in a variety of different industries that being able to sort of abstract the whoever's providing a service from the physical presence with the person who's receiving it can increase efficiencies and allow you basically to reduce some of the costs. So,
Yeah.
so how does telehealth impact that arena?
It's a great question. So again, it's 80% people, 15% process, only about 5% technology. Sambul mentioned earlier that when they do digital health, really 90% of the visits end up still being by phone. And it's the video that really doesn't change things. We are making a huge foray into digital health. We're trying to get away from the tele side of it, although we've got really, really cool updated fax machines. We're trying to get beyond that. If you read a book by Michael Crichton, who wrote Coma and Jurassic Park, in 1968, he was a young medical student, and he wrote a book about practicing medicine at Massachusetts General, and it was called 5 Patients. And patient number 4 he featured was a woman who landed at Boston Logan Airport with some type of cardiac condition, and they wheeled her off the plane into this state-of-the-art system at Boston Logan Airport, and they connected her the 3.2 miles to a physician at MGH. And through this magical thing called telehealth, they had a phone and a screen, and they had her talk to a cardiologist who asked her a couple questions. The local nurse there at Logan did a blood draw, and they figured out she was okay. And that was telemedicine in 1968. And telemedicine has really not changed since that. There's no new forcing function, new technology that's out there. What we've done, though, is taken the system, which used to reimburse us for all of these individual modalities of care, and is now just getting better about reimbursing us for keeping patients healthy, and said, why make that patient drive into New York City to visit a Weill Cornell or a Columbia doc? Let's let them stay out in Westchester or Long Island or New Jersey and do a 5-minute video visit, and we're getting much better. So we're doing digital ED visits, digital follow-up visits, and I think this is the coolest thing. If you're coming in for surgery next week and you need to have that mandatory visit with your anesthesiologist, simply to make sure that you're ready for your surgery, we're doing those in a video way and turning what is a multi-hour process for the patient into a 5-minute video checkup. You okay? Everything gonna be all right? All right, we're ready for surgery next week.
As David said, I won't leave this conversation, but I want to ask each of you from your perspective about.
The video's ready whenever you want.
Okay, great. I'll show that in just a second. So about the ways that we can potentially have even greater and greater impact on being able to both decrease costs and increase efficiency in the service. So I'm a student of the way that the combination of automation and globalization have affected a variety of different industries. On Medium, I wrote a piece on unbundling media. I used to run magazines. I'd never do that again. Unbundling higher education, which I think is one of the next big industries to get pulled apart. And that led to a piece on unbundling the middle class, which is kind of relevant to the current election. But the basic thesis, which comes from John Hagel at the Lloyd Center for the Edge, is that essentially industries are layers of services. Tonight and tomorrow, you're going to be hearing from Benjamin Bratton, who's going to talk about the stack. But the basic premise is that there's these variety of layers in different industries that along comes technology and globalization and blows them to bits, breaks apart these layers, and then new players recalibrate around each of those layers. But the challenge with healthcare is that all of the different pieces, the providers, the hospital systems, the reimbursement infrastructure is all extremely integrated. And when you try to go hit one area, it's whack-a-mole, and costs increase in some other areas. So, Jim, maybe this is a good point to show the video, but then I'd love to get some of your thoughts about why is healthcare so difficult to unbundle?
A slight context before. So the video is, so the name of the company is Medicaid Health. We're based in Cambridge, Massachusetts. We're 3.5 years old. We raised about $6 million. We're 29 of us, 20 here, 9 in India. And this is unabashedly a promotion. We don't have enough money to do multiple videos, so this is unabashedly promotional. Can't change that, but just the idea, the context was that when we came at this from technology. You were I think it was mentioned earlier, we came at it from a technological perspective, meaning we didn't come from the healthcare view, because when people saw how we solved this problem, they said it would have never have emerged from healthcare because we're just taking a completely different perspective. So with that, we'll roll the 2-minute and 40-second video. It's rated PG, so if anyone's nervous about that, you can leave now. You got it.
Every year, the U.S. healthcare industry wastes $150 billion due to unnecessary complexity, the result of decades of inefficient processes between payers and providers. But dramatic shifts in economic incentives have aligned payers and providers. They all want to drive efficiencies and rip out costs from the system. Medicare targets $12 billion of waste each year, administrative data exchange between providers and payers. Current processes rely on thousands of forms, faxing and mailing, and follow-up calls. Errors and rekeying is common. To address this challenge, we developed the industry's first electronic provider record system, a neutral, universal platform that maintains accurate and definitive records for each provider. Records that can be exchanged with payers and other third parties in their required formats. Medicare is a SaaS solution available from any browser with a simple interface, a common data store, and no software to install or maintain. It removes redundancies and dramatically reduces time and effort spent setting up and maintaining payer relationships. The platform's first module addresses enrollment. A typical provider enrolls with 25 payers. That requires managing around 125 pages of forms. The current process takes up to 4 months. With Medicare, it takes just minutes. Using our platform, a provider enters data once and enrolls with any of 3,300 payers with a single click. We hide all the complexity of the exchange, dramatically reduce staff workloads, and provide transparency into the process. Today, Medicare manages over 7,000 enrollments every week and has processed hundreds of thousands of transactions. Our enrollment module already saves the industry millions, but providers and payers want more. They desperately need solutions to other costly administrative headaches, such as credentialing, licensing, directory management, and contracting. As we roll out these new modules, we won't be increasing complexity. Each will leverage the same simple interface and common data store. Data will still only be entered once. It's just what the industry has been asking for. For years, healthcare administration has suffered from decentralized, inefficient interactions. Now, Medicare links millions of healthcare providers with thousands of payers, regulators, and clearinghouses. Medicare Health, ripping unnecessary cost and complexity out of healthcare administration and saving the industry billions. Contact us to learn more.
So
I have my T-shirt on, didn't you?
what? That's right. So what happens when you do this kind of thing in other industries, when you build these abstraction layers, or when you start to provide remote health services, in other industries, that starts to erode the existing system. But the healthcare system in the United States is so big and so interlocking and so complicated. Are these the fulcrums? Are these the places that are going to actually start to erode that integration?
So I think this is good. You know, I will stipulate to the fact that we at New York Presbyterian have this issue. Massachusetts General Hospital has this issue. Mayo has this issue. We all have this credentialing and payer issue with vendors. And so this is a kind of great solution that will get in and solve a problem that occupies anywhere from 10 to 30 full-time employees on this kind of issue. The question is, do we do a lot of these? And so do we slowly eat at the issue from the outside, which certainly we need to do. There's no reason to say let's not do it. Or do we fundamentally try to change the way that we're running the healthcare system? And I'm not a student of economics, but I've read Freakonomics. And if you've read Freakonomics, It's all about incentives. And the way that we are incented as payers is really about the way that we practice medicine. And we had this conversation, the three of us earlier. We're incented to fix broken people, not keep people from being broken. So if you keep paying a health system for fixing somebody who shows up in the emergency department 6 Saturdays in a row with a broken leg each time, we'll keep doing that. If you incent us to keep that person well, we're going to go home and find that rug that keeps tripping them and tape it down. And that's just not the way it happens today. And I'll make one other point. I also agree that there's $12 billion worth of potential risk or savings to be done. That is a technical term that I'll share with you. I think that's a Wagner, which is a wild-ass guess, not easily refuted. So, sounds good.
Well, we got the number from Providence Health and from Ascension Health. They both said it's 12 billion might be on the low end, but that's good. Anyway, what we decided to do, though, is to focus on the provider, right? If the provider is the main deliverer of healthcare, we've said we're going to focus on making their lives easier, their lives better, so that should make, if you start there, then that should make everything else better. So that was the goal. And we ended up, you mentioned about making the whole healthcare system better. The way we got started is we just replicated the existing process, but in a digital way. Because we knew if we went in and said, we want you to change because of what we're saying, no one would have changed.
Sure.
So we did exactly the stupid things that the insurance companies required us to do, but we did it electronically. And now the insurance companies are much more interested in talking to us because we can send them, send them literally notes saying, last week, the way we got Aetna to change, we sent them a note saying, we sent you 10,000 faxes last week. Do you want us to continue to do that? And they said, no. So we got them to give us a very simple digital file that we sent to them. What used to take 45 days now takes 2 days. All right, so just that one step, taking a fax to digital file, saved 43 days, which benefits everybody. Then that's just the first step. Then it ripples through the entire process.
I want to go to questions from the group in just a second, so we're talking about some of these cost efficiencies. We're talking about some of the remote delivery service. This is a big, complicated, interlocking system. If I give you that fulcrum and lever to place anywhere, where are some of the other places that you would look for really massive change opportunity? Is it IoT and instrument every person on the planet for 24 hours? What is it? What are the ways that we can other places that we can figure out where we can make those changes?
So I'll start internally and then I'll go externally. Internally, it'd be about shared data. If we were all on a common shared data platform and could easily access one another's patient data, I think we would do a much better job of keeping people healthy if they didn't feel like they only had to work with a specific provider, specific hospital, specific healthcare system. I'm not sure that's going to change in the near future. I'm a strong believer that the data is the patient's data and that we are merely stewards of that data. I would like to see that across the industry, the idea that how can we make this data available for the patient wherever they need it? We will just be good stewards of that data. So I think data sharing internally is a good internal solution. And then the external solution, I would say, is about incentives. How do you pay us as a health system and the health system down the street and the doctor across the way in a way that's focused on keeping a patient better?
So a similar idea, except for the provider data. So if you notice that there were 5 applications we spoke about. Right now, those are 5 different pieces of software, 5 different databases, 5 different user interfaces, and 5 different departments. In our hospital, 5, it's separate. So the CIO looks at that, or the CFO, and says, this is crazy. I can't share data among them. The first thing you do in a credentialing is put a demographic data in. That's what an enrollment is, right? So it has to be redone each and every time. So the idea is to have one common data store, one common user interface, that can be then leverage their data across a myriad of uses to the providers, other providers, payers, insurance companies, that's redundant, and regulators and so on and so forth. So that's our strategy, is to get rid of those 5 different databases that don't speak to each other and put it all in one to leverage it. Yeah.
Questions?
Robert Klitzman from Columbia. My understanding is that a lot of electronic medical systems still don't talk to each other. Cornell, Columbia, for instance, have different systems. How do we overcome that? And do we need some kind of centralization or harmonization? And what are your thoughts on that?
Sure. So I don't see that changing anytime soon. It's unfortunate if you think about the American Recovery and Reinvestment Act of 2009, essentially the big fix. There was a $19 billion investment in electronic medical records. And the federal government said, if you make your medical records interoperable, then we will reimburse you. But the standard was so low. I can send you a couple packets of data, you can send me a couple packets of data, check the box, that's it. It's not really interoperable in any way. And the EMRs, the EMR vendors were really not incented in any way. They were just helping everybody get live on all of these new systems. So we find ourselves having built these really great complex systems within our own health systems, but that aren't incented to share data in any way. And so we're doing it through a lot of backdoor work. Now, we're working with the federal government and a national initiative called the Karen Initiative with the ONC and HHS to try to share data, but it's almost like trying to tie tin cans and string together between glass skyscrapers.
So, and therefore, we should do what?
Therefore, we should establish better standards for sharing data. The next generation of electronic medical records, because there's always upgrades that are happening, should get better and better about sharing data. I will give the EMR vendors a lot of credit. Internally, they do a much better job of sharing. So if I'm on a EMR A, I can share data really well with all of the other providers nationally who are on that electronic medical record, even internationally. But going from A to B is very difficult, and the standards that we've established, continuity of care documents, are pretty much like electronic faxes. So a couple-page PDF version of somebody's care. Sure, you can shoot it back and forth electronically, but you're not going to interact with it in any way.
Mark Bartolomeo, I'm with Verizon. And when we've seen disintermediation or transformation, we're very often talking about the impact of the consumer, on the business model. Are you starting to see any changes like we've seen that millennials have driven or digital first type of demographics have driven that say, this is not the way I'm going to do business, similar to how they're doing it in the transportation industry or in the hotel industry or the shared economy approach, particularly when you start talking about data and the way that particular demographic views their data and trust?
I think we're probably a generation away, at least from a physician and a healthcare point of view, of seeing the patients as the center of the universe. So even when we build really good portals or front ends, in many ways, we ask a patient to log in and request an appointment, and it might be next Thursday or Friday between 1 and 5 p.m., almost like a cable television model. When might the person show up? Instead of saying, sure, I can give you that endocrine appointment 2:30 on Thursday. And we still haven't quite flipped nationally from a healthcare point of view to put the patient in the driver's seat for all of this. I think it is coming, but it is coming slowly, and in many ways we are deferential to the physicians who, quite frankly, are really the brains of the operation. Without the well-trained physicians that we have doing the care and being deferential to them and their skills, we're nowhere. So we're trying to balance between a generation of physicians who are really good at what they do and were brought up in an environment where they were the center of the universe, and a new generation of people who expect to be able to get health care in any way that they want.
Do you see a place where the consumer will get leverage in that ecosystem?
Yeah, actually, I think it gets back to the question about the data sharing. When I do a better job of sharing data and your data can be wherever you want it to be, then you can say, oh, great, I can have my data wherever it is. I'm going to go to this hospital or this doctor instead of the one that I used to go to. So it's almost a chicken and the egg thing. When are we going to get better at sharing the data that empowers the patient?
One last thing, just as a joke, actually. Given what happened last night, the Trumps get their health care at New York Presbyterian, right? Yeah, all right. I know that his son was born at New York Presbyterian. That I know for a fact. Anyway, thank you.
Nobody is happier to see the end of the election than I am, given the number of very visible people and the idea of Russian hacking that's going on right now, and the fact that we're responsible for a lot of healthcare data.
So I wanted to think, you're saying, to jump in on point. I wanted to take this on reservation. So it's actually we're on flip the question. It isn't just necessarily that we mechanistically make the individual the one who's a little more in the driver's seat. Here's my question. It's going to put you guys on the spot, and then I'd love to get the thoughts of the attendees as well. We have a model of sickness. We have a model of fixing things only when they're broken. And our model is not about wellness. Our model is not about proactively healthy people. My wife and I, we got a 20-year-old, and we pay an incredible amount in insurance, and we're some of the healthiest people on the planet. But the system does not reward us. As a matter of fact, the system is costing us tremendously for it. So when I asked you for fulcrums, you guys didn't say, single payer or anything like that. That didn't immediately come up. But is the model just completely wrong? Are we built this entire system off of a false premise, which is that you only need to think about when something breaks, and all of the negative externalities that come from that are on that premise, as opposed to figuring out ways to completely flip the model so that we have the rewards for wellness that can help to change behavior as opposed to the penalties for sickness.
I'll take a stab at it. So I'm on the board of a hospital in Boston, and we were a pioneer ACO, accountable care organization. And last year, I believe every dime of our revenue was a shared risk revenue, 100%. I believe it was 100%. If it wasn't 100%, it was 99%. And so we're really actively trying to do that, right? We're a relatively small hospital in Boston, and we can't just emulate Mass General Hospital because they'll crush us. So we're trying to do innovative things, and we've bought 4, 5, or 6 little hospitals that are out in the suburbs, and we're integrating them now. So, and we're pushing people out to the suburbs for there's some things you'd have to come to Boston for, open heart surgery, but for knee surgery, you can do it in a cheaper suburb, and we're actively trying to do that. And we're experimenting with ACOs with lots of different payers, trying to make it so that it is the healthy patients that, or keeping patients healthy is how we get better rewarded. So we're trying.
Why did that change, Jim, and how recently did it change?
Why did what change?
Why did it change that you're going for outcomes now?
Because we needed to do something that was different. We wanted to speed ahead on being an accountable care organization hospital. And we're number 4 in Boston, which we're 1/5 the size of Mass General. And we knew that if we didn't do something innovative and fast, we would just be left behind. Right. So we changed that because we saw that as a wave of the future. We saw that as a future.
So you see Obamacare as a very positive driver
Yes,
of progress?
Absolutely,
Okay.
positive.
Sorry for jumping.
So I think that you also highlighted the incentives model. So the ACO model pays health systems to keep people well and reimburses them in that way. And so the more we see of that, I think the way will change. I'll give you the most striking example. Like I said, I only got into healthcare 10 years ago from the telecom industry. And I was amazed that about 8 years ago, all of a sudden we were talking about patients. And I said, well, what happened overnight? Well, there was a change in the way the federal government reimburses health systems and hospitals for the care that it delivers patients. And what it does is it follows up with the patients afterwards and sends them a little piece of paper to their home and says, how did you like your care? Did your physicians communicate with you? Was it quiet at night in the hospital? Well, all of a sudden, we are installing ways of measuring ambient noise and focusing on the loud ice machines on hospital wards in a way that we never did before. And hospital administrators are walking the halls of hospitals at night saying, why is it so loud at night? Why can't our patients sleep? And so it is all about incentives and how we're getting paid. And that's really what's driving healthcare change.
Right, and inevitably, what you need that to do is to just change people's entire perceptions, because it really, I mean, in virtually, in Silicon Valley, virtually every company thinks at some point about the customer experience and is actually designing its processes to get the best possible customer experience. But we don't call them customers; we're calling them patients. Mm-hmm. And so there's I don't think of myself as a patient, even though that's what I look like to the system right now, even though I'm well. And so what I hear is not just changing, is that by changing the incentives for the individuals in the system, you're changing the mentality about them, by the way that they approach the delivery of service. Do you have any thoughts on this? Or?
That's true. So I'll make 2 points. One is a point that Sambul made earlier about Stanford, in that often we don't know who our customers are. So are your customers the patient's family, the physicians who practice in your hospitals? So that's one challenge. And then it gets to the healthcare industry, and you mentioned Silicon Valley and what we're doing here. There's a mindset that the next cool piece of technology will solve problems in healthcare. And what I see more and more often is small companies that have a good solution for managing patients in the home, or when they're well and keeping them well. And they have great solutions for that interactive. So our care coordinators can see Mrs. Smith and Mr. Jones and how many sit-ups they're doing, how many miles they're walking, what their creatinine levels, and all of these at-home things. And they bring these solutions to us. And I look at them and I say, who do you think is going to use that? We're not quite paid to keep people well. I think there's an expectation in the industry, in the technology industry, that we have absolute huge airplane hangars full of people at desks making phone calls and checking up on people at home. And even in a $7 billion health system, I might be able to introduce you to our 17 care coordinators individually by name. So we're not at the level where large health systems have these workforces that are incented to keep people healthy. We're still doing really good emergency department care.
Yeah, Andrew Thompson, I'm the Chief Executive of a company called Proteus Digital Health. I just want to react to this notion of the way you frame how bad, quote unquote, the sick care system is. I would really think it's more positive to say, look, we have a magnificent sick care system. It is fantastic. It was built in the last century using the best technologies we had then, and it does the job for which it was designed to do superbly well, acute disease and trauma. What we're now alluding to is we have a whole new set of healthcare challenges that are mainly chronic and ambulatory. They're experienced in community settings, and they're everywhere in the world. And the solution here isn't necessarily to look at enterprise transformation of the sick care system. It is to build a healthcare system to complement it and then add to it. And I would argue that when you look at that new challenge and you see it as a separate opportunity, you can start to make use of the technologies that are extant in the 21st century, and you can start with a blank sheet of paper and you can build something very different. And they will complement. And if you look at how digital transformation in other sectors has taken place, it is very clear that digital and physical belong together, and Amazon will have retail stores, right? But this idea that we're going to make progress by essentially critiquing something that does the job for which it was built and designed very well, in my view, is a very difficult premise from which to win an argument or to build progress.
So a longer conversation I'd love to have with you over drinks. I'll give you that the system has tremendous capability. It's always at what cost? And as 70% of U.S. GDP, it's an extraordinarily high cost. I love Teslas. They are one of the best efficient, best designed machines on the planet. I can't afford one. And so we can't give everybody a Tesla to have the most, the best way to be able to be transported from point A to point B. So to me, it's always at what cost. I'll buy to some extent the premise of you can't just criticize the way it exists without without trying to fix it. The truth is that Uber didn't say let's fix the taxi industry. They said let's come up with a completely different way of meeting the customer's needs. So you can innovate on the edges, or you can innovate in the middle. And my thesis is, we have to do all of it, and it's really, really hard to innovate in the middle with something that's of that size. That doesn't mean we shouldn't try. So, just a couple of thoughts, last-minute thoughts. Any other places that you think we should be focusing our energies, or it seemed we were sort of heading more towards a little bit of single-payer stuff, and maybe in the new era that's not going to happen as much. Are there any other places you'd want to stick a lever?
I'll jump in and let Jim have the last word. First of all, it was really well said, insightful way of going about this. The only other area I would say, and this gets to your point earlier, Gary, is transparency. So you mentioned that you spend a lot of money on your family's health care. If you were working for a large employer that was paying for most of it, you probably wouldn't notice or wouldn't care. So the more transparency and the more that we as consumers of healthcare feel that, I think the more involved we will be and demand better service, better care, and ask questions about some of the inefficiencies of the system that Jim and his company are trying to address.
Yeah, at our hospital, we're trying to take those 6 or 7 different hospitals that we have and make it seem seamless to the patient and fully integrated. And we've always been a transparent hospital. It's always been one of the #1 things that we focused on. We were small, so we had more flexibility, and that was one of the things we competed on. So I agree with all that. And he forgets more than I know, so as we've discussed earlier.
All right. Listen, please thank my guests here. Thank you all.